So about the headaches, I know it's a broad topic a little bit. There's a lot of possibilities or diagnosis for headaches. And it's a very common presenting symptom. But however, these are like the most high yield topics or diagnoses you should think of. I know the doctor covered a lot of different possible diagnoses or differentials for your lecture. But mainly, he should probably be focusing on the primary headaches, which would be migraine, cluster, and tension when it comes to questions, hopefully. But we'll have an overview about everything else just in case. There's also a lot of molecular medicine and pathophysiology and physiology and theories behind the cause, which are all I'm going to skip because for the sake of time and because they're not high yield and most of them are theoretical, not proven. So if you guys have any questions, feel free to unmute and ask or type in the chat, okay? So this is a scenario. This is a question from Ambos. They have really great questions in case you would like, but I don't know if they're at your level. So your scenario, in case like you have an exam, would be not asking you for the diagnosis, which would be one of the headaches that you're aware of, but actually more likely to ask you for like treatment or prognosis or something like that, because questions are not that easy anymore. How would you narrow down your differentials? Would be based on the age, the gender, how long is the headache going on for? Like in this case, the patient's having it for 5 months. And how often are the episodes? So 20 days per month. That's 20 out of the 30 days. How long do they each last? This also is significant. How does the pain present, the headache present, the description of it? So headache is one of those topics where the history is very important. So the history taken for skills to Socrates, it's actually very significant when you're narrowing down the differentials for the headaches. Now, it's also to keep in mind the associated symptoms. So nausea, vomiting, photophobia, phonophobia are not there. So we can rule out some of your differentials. Does it improve with ibuprofen or does it not? And so on. So we'll go over this question again once we're done with the primary headaches, okay? So again, primary or secondary. Secondary, you're expecting it to be secondary to trauma, to infection, or so on. Well, primary would be the tension, migraine, cluster. Tension being the most common, followed by migraine and then clusters. So I found these very nice pictures in Ambos. They practically summarize everything you need to know about the 3 primary headaches. So here you'll have the more common in females, the duration from like, it starts from 3 to 3 days, 3 hours to 3 days for migraines. It's episodic, so you're going to be expecting multiple episodes. Young age usually, and it improves with NSAIDs. So you're going to give the patient, or the patient will be taking ibuprofen and improving, or triptans. Triptans is now the best treatment for migraines. For long-term treatment, it's we'll discuss the long-term treatment in a bit. And there's here the warning that you could have medication overuse headaches due to overuse of the triptans. We'll go over this again. For migraines, what's unique about it is that you have prodromes, aura, and then migraine itself, the headache itself, and then the postdromes. So we'll cover these again in a moment. You have the triggers available and the character of the pain. So these are very nice so as to go over if you're comfortable with photograph with the photos. So migraines, classic, are with aura. The common ones are without aura. Only 25% of migraines present with aura. So the fact that the patient in your scenario does not have an aura is not an exclusion for migraine. It's not enough to exclude migraine at least. But it's would be a very significant presentation if it's in your scenarios. Is the voice lagging? Okay. Is it still echoing? Just a second.
Is the voice clear now? Is it clear now or still echoing? Okay, sure. Let's continue. So as I covered in the picture, here you have it. The prevalence is available. Genetics are not that high to cover, but if you have family history, it's good to keep in mind. These are triggers. You need to know your triggers. For females, menstrual cycle is a big trigger. Caffeine. So if your patient is like, if it mentions a scenario that they drink a lot of coffee, if they're stressed, having a stressful lifestyle, these are all indicators that you'd be leading towards migraine more. Now, this is how a migraine would present: prodromes, which we'll go over them, the aura, followed by the actual headache, and then the postdromes. So keep this in mind. It's not just headache on its own, it's a package. So these are the prodromes. They could present in multiple ways. Could be neurological symptoms, especially photophobia and phonophobia. These are two very important presentations. Could be just constitutional symptoms, nausea, vomiting, also could be there, mood swings. Usually your patient, migraine is once it's diagnosed, so they'll be episodic, so they will be aware of their own prodromes. And then the aura, of course, which would present something similar to this. The headache, which we said would last 3 hours to 3 days, and its unilateral presentation. It's important to know if it's unilateral or bilateral. It's also a big differentiating factor in your questions, so it's easier to narrow down the choices or exclude some choices. And then the postdrome. So this is the general presentation of migraines. I hope it's clear. It's not that difficult. It's important to differentiate each presentation from another. So migraine, I think, is very unique. So hopefully you'll not get this confused. How do you diagnose a migraine and as an actual classification? I would say this is a bit outside your league of knowledge or what you'll be required because you're not diagnosing them, just choosing the right answer. But you can go over it for the sake of completion. So it would be 2 out of the 4 characteristics. So we'll mention them all. And the fact that there's nausea, vomiting, phonophobia, and photophobia would be also indicating that it's an headache. Sure, I'll slow down. In other types of headaches, you'll find that one of the diagnostic criteria is that there's no phonophobia, no photophobia, no nausea, no vomiting would be part of the diagnostic criteria. Okay, we'll come to it. So the primary treatment would be to, of course, do lifestyle modifications, avoid the triggers. So let's say we mentioned there's menstrual cycle. If it's an issue, it could be regulated by medications. If it's stressful, then again, lifestyle modification, reduce the stress, and so on, depending on what is the cause. Then the actual treatment would be either episodic treatment or preventative treatment. The episodic, so this is when the patient already started having the migraine. So let's go here. Once phase 1 starts, usually the patient, if they have multiple episodes, they are aware that this is a migraine coming on. You cannot start medicating here. They can try, but here's where actually when the medication starts to be effective. So you cannot stop phase 1 or phase 2. So you're going to have phase 1, phase 2, and they're going to recognize the headache, that it's a migraine coming on, and then they're going to take an NSAID or just ibuprofen, a normal painkiller, on acute settings. They can take triptans, which is usually for moderate to severe headaches. And that's it for the episodic treatment on the acute setting. Now, when the patient is presenting with multiple episodes, or you want to do long-term management, you want to avoid the episode from taking place in the first. So in this case, you do prophylactic treatment or preventative treatment. So this is we're going to mention it in a little bit. So this is to prevent the attacks from coming on in the first place, instead of just treating them once they're on. So acute, mainly, as we said, triptans. They have their contraindications. So once one of these contraindications are present, you have to avoid triptans. So coronary artery disease, vascular diseases in general. You cannot take and severe hypertension. So in this case, you'll have to go with another form of NSAID. Now, your goal is to reduce the headache and to reduce the impact on the activities of daily living, which could be achieved mainly with the triptans. It's the treatment of choice. Now, for the prophylactic treatment, who is qualified or who is indicated for you to take for them to be taking prophylactic treatment. If their migraines are more than 2 per month, so migraines only 2 per month, yes, like once every 15 days, let's say, it is very it has a high effect on lifestyle. So it's important once it's more than 2, then you need to give them prophylactic treatment. Also, if they're lasting for several days and if they're very severe. And of course, let's say if the triptans, which is your treatment of choice, is contraindicated, then you'll probably lean towards prophylactic treatment. So what could you give as a prophylaxis? You can give seizure medications. Valproate is usually the one you will see commonly said in scenarios or in questions. Blood pressure medications could be either beta blockers or calcium channel blockers. Propanol and verapamil are also the 2 most common ones you'll be seeing. And for antidepressants, you see amitriptyline a lot. You can familiarize yourself with the others as well, just in case they're going to be in your exam, but I doubt it's not as high yield as others. Like a last modality, last line you choose for treatment is to do the botulinum toxin. So it's basically Botox, you're doing injections to prevent the headache. Are we clear for migraines? Okay. So cluster headache, again, same graph or same diagram to the cluster. It's more common in males, 20 to 40 in age. You're going to have short episodes. It's going to be, can migraines present bilaterally? Yes, they can, but it is unlikely, very unlikely. So, and I do not believe they will get you a scenario with a migraine presenting bilaterally. A migraine mainly be presenting unilaterally. Now for cluster headache, yes, the duration is going to be 30 to 40 minutes. It's a short episode, but it is frequent. So you can expect 3 to 8 attacks per day. So there are 30 minutes, 30 minutes, 30 minutes each. Mainly at night, and it has a lot of symptoms additional to it. So you're going to have like inflammation or tearing of the eye, a conjunctival injection, so the eye is going to be red. It's mainly going to be also sided, unilateral. Photophobia might be there. Sweating would be there, flushing, rhinorrhea, so you have a runny nose, a nasal congestion, so the nose is full. Now, the attacks could be regularly, I mean episodic, just regular episodes, or it could be chronic, so continuous. So let's say, yes, there are multiple attacks per day, but it could be, or let's say, 3 days per month, or it could be continuous. It has its triggers, of course, alcohol, insomnia, nitrates, bright light, and the character of the pain is stabbing or burning. It's very severe regarding the pain. Now, cluster headache, I think we covered all of this from the picture. You can go over it by yourself if you're interested. Same here. So description would be severe unilateral orbital, supraorbital. So orbital is around the orbit, so around the eye. Supraorbital is above it. This area affected. Last 15 to 180 minutes, we went over this too. Associated symptoms, we cover them as well. So you should be fine with that. Now, how do you treat cluster headache? Now, this is an understood phenomena, but high flow oxygen will be your best treatment that you can give to your patient. So once you give them oxygen, it should treat it right away. You can also give them triptans or NSAIDs, but nothing is going to be as good as oxygen. Why? No one knows why. Just there. There are theories, but not confirmed. Now, prophylactic treatment, if you're talking about long-term management instead of just acute onset of treatment, you don't want to wait for the headache to develop to give them oxygen. You want to prevent them from getting a headache in the first place. We're going to go with verapamil, all right, which is calcium channel blocker. These are other medications your doctor listed. Feel free to go over them, of course, just in case he brings them. But he's more likely to bring them as distractions in the choices than an actual answer. But if you want to be on the safe side, you never know. Okay, so this is more details about oxygen inhalation. You can go over it on your own, but basically in 20 minutes, your headache will be treated just by inhaling oxygen. So, tension headache. Any questions about cluster before we move on? Okay, I'm assuming it's clear. Yes. So tension headache, it's the most common primary headache, or the most common headache generally speaking.
I have
It's more in older. Yeah, sure, go ahead.
sorry. Why is sleep a trigger?
Why is what a trigger?
The REM sleep.
It's insomnia that is a trigger, as far as I believe. So here you have insomnia. Why is REM sleep itself? This is what your doctor put in the slides. What I found in my own knowledge and online is more of insomnia. So I'm not sure why is REM the cause.
Okay. Thank you.
Lack of sleep, on the other hand, is a cause. I think both migraines and cluster are usually what?
That does make more sense.
Okay, that's good. I'm glad. Migraines and clusters are both episodic and unilateral. Yes, you are correct. What the frequency between them? The frequency is that cluster is going to be an episode, just a short episode, 30 minutes, a very sharp severity. Get another attack in, let's say, 2 hours of another 30 minutes, and so on and so forth. While migraine, on the other hand, is going to be 3 hours continuous, or even continuous for 3 days of continuous pain. All right, this is the difference between and not just the frequency, you can also differentiate between the two of them through the associated symptoms, the nose manifestations. It's a classic presentation. Does this make sense to you?
Yes.
Okay, thank you. Let's start with tension. It's more in elderly people, not older people, so 30 to 40 years, which is a later onset compared to cluster and, and migraine. It's the most common, as we mentioned. The duration starts from 30 minutes to 7 days. Persistent. The character of it is a classic band-like, and it's bilateral. Just discussed. It's the only bilateral one. Okay. Lapsing in the episodes, but it's the treatment of choice you would do. So how do you approach a headache? Of course, you need to know if it's primary or secondary, which you would take again by history and the physical exam. This is why history is very important. And then if it's primary, you can treat it. If it's secondary, then you're going to need more follow-up and workup investigations. This is briefly, we'll go over the history and the physical. So the questions that you need to ask, is it the first time, unilateral, bilateral? Let them describe the headache. Was there anything, any characteristics that are specific, any associated symptoms that will help you? Let's say like cremation, for example, then you're leaning towards cluster headache right away. Let's say in the character they say it's tightness or band-like, then you're leaning towards tension headache. Bilateral, once they say bilateral, thinking of tension. Unilateral could be cluster or migraine. Other things, so anything, on the onset, or if you're talking about how does it start, was it preceded by trauma, infection? Because then you're going to be thinking of more secondary headaches, not primary headaches. anything makes it better. Let's say dark room. In this case, the patient is having photophobia. So it could be migraine or cluster also in this case. Yes, family headaches, family history, sorry, could be in migraines and subarachnoid. We'll go over subarachnoid as we go on soon. Physical exam, vitals, of course. So if the patient has fever, so let's say fever and headache, if there's also mixed stiffness, you're going to be thinking meningitis is the cause. So you're going to investigate for that. Trauma, so you're going to think of a hemorrhage, let's say subarachnoid, subdural, epidural hemorrhage. You're going to do probably a scan and see exactly. Eyes is a very important part of your physical exam. Papilledema is a huge red flag. Papilledema could be indicating the idiopathic intracranial hypertension. So this is a form of headache that can lead to blindness and permanent vision loss, basically. So you really don't need to act fast. If you have otitis media, it's an infection, could spread through the bone to the brain and cause headache also. So these are all questions that you need to cover. You have also the physical exam, but for the sake of time, because this is not going to be likely in your scenarios, we just jump to secondary headaches. Any questions before we move on?
Can you show the comparison picture again, please?
Between what, the three primary ones?
Yes, please.
Sure. There you go.
Okay, thank you.
You're welcome. These pictures are from Amboss. I think you guys have access to it, right?
Yes, we do.
It's very helpful. Okay.
Check it out.
So secondary, thank you. Secondary headaches could be hypertension, meningitis, subarachnoid. We'll go over them all briefly and fast, inshallah. So hypertension, you're expecting it to be a bilateral headache, of course. Think of it as your vessels are bilateral. Throbbing end will increase with activity. What else was bilateral? And you could think of tension, but however, tension did not increase with activity. So this is a differentiating sign. So you don't confuse them. This was, this slide was hard to decode, to be honest. I'm assuming here he was mentioning pheochromocytoma. I don't know if you guys took it or not. It's basically a mass in your adrenal glands above the kidneys. It could cause very, very severe headache, very, very severe hypertension, so causing headache. But other than that, I'm not sure what exactly he was trying to say. But generally for hypertension, it's unlikely he'll get to your question about hypertension, unlikely to get anything aside from the primary ones. But it's good to keep in mind as an answer. For meningitis, I mentioned it in the physical. If you have fever, hypertension, neck stiffness, you're leaning towards meningitis right away. How do you diagnose this? Lumbar puncture. You suspect it clinically and do LP. It's dangerous to do LP without doing a scan of the brain first to avoid herniation. I don't know if we cover this in neuro or not. I don't want to confuse you with it. Subarachnoid hemorrhage is a very, very severe pain. The patient is going to come to you complaining that this is the worst headache or this is the worst pain they ever experienced. And you can see here small vessels hemorrhaging, and it's also described as a thunderclap. So these are the signs for subarachnoid hemorrhage. I don't think you need to go too much into details, but think of it as like age older people in general, because that's when your vessels become more likely to think of it as break and bleed. Yes. Now, subdural, I like this picture. You can see it's subdural hematoma or subdural hemorrhage, would be showing as the banana sign. I don't know if they taught you the banana sign, the banana pear. It's basically, you can see it on a CT scan easily, or MRI. Usually the patient is going to be post-trauma. It's the most common cause, I would say, or head injury in general will be the cause. And then the bridging veins are going to rupture and you're going to have bleeding. So your patient is also going to be more likely old. Again, we said they're more likely to hemorrhage or with a bleeding disorder. Again, for the bleeding to happen. Subdural hematoma, same thing here. These are other things you could be presenting with. Less likely scenario to get. There are more other high yield topics. but it's a possibility, so keep it in your head as differential always. Now, giant cell arthritis, it's not common, however, because it's more of rheumatic disease, so rheumatology related. Your patient is going to be an elderly man, most probably in their 60s or above, and they're going to have the temporal artery visible. You can spot it in the inspection, like if you're doing physical exam, you can spot it. I think there's a picture, yes, here, the temporal artery. So this is a huge red flag also. It can cause permanent vision loss, so you act as fast as you can. In this case, the diagnosis for it is through a biopsy. However, you cannot wait for a biopsy result. Let's say if the patient comes to the ER, there's no pathologist, you cannot take a biopsy and send that sample right now. It will take, let's say, 12 plus hours to get the results back. So what you do, the treatment of choice would be to give corticosteroids. So give it as soon as suspected, not as soon as when diagnosed, because by the time of diagnosis, you're risking vision loss of the patient, which you do not want to cause that. So give corticosteroids. This is the main thing you need to know about it. You can skim the other details just in case, or like for sake of completion. And these are the most high yield things you need to know. Now, herpes zoster ophthalmicus, the good thing about it is that there are clear vesicles. So once you see vesicles, or once the scenario says there's a rash or vesicles, we're going to go with ophthalmicus or zoster ophthalmicus. What your patient is going to be likely elderly, diabetic, or immune compromised, because these are things that weaken your immune system. So you're more likely to have reactivation of the infection. And you guys know the neuralgia of the trigeminal nerve, right? Or was it, can I repeat what? Sorry, what was asked? Repeat the temporal artery. Okay, sure. So temporal arthritis. So this is a giant cell arthritis. It's a kind of it's a vessel disease. It's a problem in the vessel. The patient is going to have this very clear temporal artery bulging, and they're going to be presenting with a headache. Now, this has a risk of vision loss, a high risk of vision loss, to be honest. So what you want to do is, how do you diagnose it in the first place? You need to take a biopsy from the vessel and send it to pathology lab, get it analyzed. Now, this would take too much time. So once you suspect that this is giant cell arthritis, the first thing you do is to give corticosteroids, because giving a corticosteroids dose that's not that high, to be honest, to a patient that does not have giant cell arthritis is better than not giving it to a patient that has giant cell and will end up losing their vision. Is it clear? Okay, great. The zoster ophthalmicus is, as you mentioned, vesicles, unilateral pain. Usually you're going to have a rash report, maybe even an infection report if it's a primary, not a reactivation. Okay. And herpes zoster ophthalmicus is associated with the trigeminal nerve neuralgia. Just keep this in mind. It can be in your question. How do you treat it? You treat it with acyclovir. It's an antiviral. Also, you can give steroids, corticosteroids, because it can cause facial nerve palsies. So this is a way to treat it in case it's causing Bell's palsy. Okay. The IIH, or the idiopathic intracranial hypertension, is another dangerous type of headache that can cause vision loss. So even it's not common at all, but once you're suspecting it, it's very you need to be alert, because papilledema will be there. Papilledema. So this is in your eye. When you're doing an eye examination, you'll find that the optic disc is edematous, so it has edema. It's more swollen. And in this case, it's an indication that there is increased intracranial pressure. So once you have this, it's intracranial hypertension. You'll be suspecting the idiopathic intracranial hypertension causing the headache. Here, the treatment goal, the first thing before you even relieve the pain or the symptoms, is to preserve the vision, and then you will treat the symptoms. You could always do CSF, decrease intracranial pressure, give them medications, remove if there's any underlying causes in general, treat them. Loop diuretics, if there's for the hypertension general LP. Again, LP will be for the CSF drainage, and corticosteroids. You can do an LP shunt, so it's continuously being removed instead of just draining a specific amount. Lastly, we have headache and epilepsy. So post-seizure, after the seizure, you could develop a headache, or the patient could be developing a headache. This is expected to go within a few hours. Not, I would say, around 5 hours. If it's continuous for longer than that, then you should be concerned and do other investigations to rule out other causes. All right, but there's a connection in literature between migraines and epilepsy, so it could be that. A prophylactic would be valproate, which I don't know how important would that be for your exam though. Now, this is another question. It's not that complicated. You guys, if anyone wants to go over it.
Assalamu alaikum.
Okay,
So
I can
I
go
think
over it. Yeah, go ahead.
so. I think because they said that she has pain while chewing and brushing her teeth, it's probably trigeminal neuralgia.
Yes, perfect. And there's a vesicular rash.
Yeah,
We
so it's
said
zoster.
rash. Yes, perfect. Yes. Any questions? Yes, whoever answered. Yes, Sarah, you're right. Correct. This is it for the PowerPoint. Anyone having any other questions? Option C and D. You do not need to differentiate between option C and D. This is a bit, I know this question is a little bit outside the topic of the lecture, but I wanted to make sure that you will be able to identify even something as vesicular rash and the teeth aggravation and all of this as trigeminal. But other than that, this is a bit complicated, yeah. Like cluster, you guys know how to differentiate cluster. Temporal arteritis also, we have discussed the others, not really, so I will not worry about it. It was not mentioned in this lecture as well. Why the first case was tension? This one? Okay, so in this case, your patient is having dull pressing, non-pulsating holocranial pain, does not increase with exertion. We said yes, okay, normally tension comes as bilateral. Can it be unilateral? Yes. Can migraine be bilateral? Yes. Unlikely, but it's a possibility. Here, the symptoms do not increase with exertion, which is, again, something for tension. There's no nausea, vomiting, phonophobia, or photophobia, which we said was part of the diagnostic criteria. The absence of these symptoms was part of the diagnostic criteria for the tension headache. She takes ibuprofen regularly, and the headaches are improving on it, which again aligns with the tension headache. Again, stress. Stress is one of the leading factors that causes it, which is why often we have part of the chronic treatment is lifestyle modification and physical therapy and such. If she has stress, you could be thinking about migraines as well, but then she denied the most common associated symptoms of migraine, so you would not be thinking of it. For long-term therapy, it's not 20 continuous days. The episodes are for 2 hours, which is within the range of tension headaches. It's 20 days per month, so there's 20 out of the 30 days she's getting a headache. But it's not for continuous. It's the frequency. Yes. Any other question? Post-herpetic neuralgia. So it is after the herpetic infection, there could be neuralgia, which is based like neural deficiency deficit after the herpes infection if it was not treated accordingly. Unless it was covered in other lectures, do not worry about it. This is maybe for your extra reading if you want. For headaches, do not worry about it in this lecture. It was not covered by the lecture's slides, so don't go too deep. Okay, I'm assuming it's clear for now.
So, doctor, so what was the treatment for this disease again, zoster?
Zoster, you give acyclovir, or basically antiviral. It's a viral infection, so you treat it by antiviral. You can also give, it depends if it's involving, let's say, facial nerves, then you will need to give steroids. And I think there was one more thing, maybe a tricyclic, amitriptyline, maybe, but this is only for the pain control, not the actual infection. Zoster headache, sure. So here it just, the patient is going to be presenting with vesicles or a rash. So this is like one of the biggest signs. Once you have a picture like this, or it mentions in the scenario that there are vesicles, consider zoster as one of the diagnoses possible. It will be a unilateral pain. Your patient is going to be either elderly, maybe diabetic, or even immunocompromised. So they're having HIV, they're post-transplant, or they're on chemotherapy, because all of these things are make you more susceptible to the reactivation of herpes infection. Okay. Now, here's the post-herpetic neuralgia. So if it persists and if it's not treated, then you're going to have post-herpetic neuralgia. The doctor did not cover it in depth, so I would say it's not on the higher yield, on the higher yield side of things, but it's good to keep in mind as a potential question. Okay, all clear? Okay, thank you guys for attending. I hope you benefited. If you have any questions, feel free to contact me.